Everyone. Welcome to Ethics for Lunch for November. My name is Mark Hughes. I co-chair the Hospital Ethics Committee. As many of you are aware, that this is our monthly session with the hospital community, sponsored by both the Johns Hopkins Hospital Ethics Committee and the Berman Institute of Bioethics. Opportunity to discuss issues of clinical ethics. And always instructive to have a panel come and discuss these interesting issues and then invite your feedback and questions about these things. I'm going to turn it over to Lauren Berninger. She is a new faculty member in palliative medicine. We're thrilled that she's joined us. She did her fellowship here in palliative medicine and has been on the ethics committee now for the past year. She got her master's in bioethics through the Berman Institute. So she brings a wealth of experience to this session, and we're glad that she's on the faculty. So over to you, Lauren.
Thank you, Mark. It's really great to be here today to discuss what we think is a really fascinating case. We have a lovely panel put together because I think it takes a village to really address some of these ethical issues that we encounter in clinical practice. So today's discussion is going to be on deciding whether to disclose HIV status to authorized decision makers in situations of life-threatening illness. So both myself and all of the other members of the panel have no disclosures. These are the objectives for today's session. Number one, we want to apply the ethical principles of respect for autonomy, beneficence, and non-maleficence to a case and evaluate the conflicting ethical obligations. We want to discuss stigma associated with HIV and its potential effects on medical decision-making. We want to identify situations when it is appropriate to disclose a patient's HIV status to a surrogate decision maker. We want to review clinician ethical obligations to protect patients with highly sensitive medical information, such as a diagnosis of HIV. And we also want to briefly review any laws and policies that are in place to protect patients with highly sensitive medical information. I think most of us are familiar with HIV. It's been around for many years, over 4 decades. But briefly, for any of the non-clinicians in the audience, HIV is a viral infection, which primarily targets what are known as helper T cells, or CD4 T lymphocytes. And without treatment, this leads to a very profound immunodeficiency and a susceptibility to opportunistic diseases. Transmission is primarily through sexual contact. It can also be through blood transfusion and contact with infected needles. It can also be transmitted from mother to infant, and in some cases through breast milk. Looking at data from 2015 to 2019, the most common mode of transition was male-to-male sexual contact, followed by heterosexual contact, and then by injection drug use. This actually is a little bit different among males and females. So among males, it's male-to-male sexual contact. Among female, the most common mode of transition is heterosexual contact. So just briefly talking about progression of HIV infection. So in the acute phase, about 2 to 4 weeks after infection with HIV, patients can experience a flu-like illness, which then subsides, and patients go on to develop what's called chronic or latent HIV infection, where they are most often largely symptomatic during a period of about 10 years, but the virus is still transmissible to other people. And in the third stage, the most serious stage, patients progress to the acquired immunodeficiency syndrome, also known as AIDS. At this point, patients become largely symptomatic. They're at risk for opportunistic infections and other diseases, cancers, neurologic disease. And they have a very poor prognosis without treatment at this stage, prognosis of about 3 years. I wanted to give some examples of AIDS-defining illnesses. These include infections, malignancies, and neurologic diseases. Some of these infections you've probably heard of, especially from the early days of the HIV epidemic. Things like PCP pneumonia, pneumocystis jirovecii, viruses like CMV, HSV, and the JC virus, Other illnesses like toxoplasmosis, fungal infections like Candida, tuberculosis, malignancies such as Kaposi's or Kaposi sarcoma, lymphomas, especially B-cell lymphomas and primary CNS lymphoma, and invasive cervical cancers. Also neurologic diseases such as HIV-associated neurocognitive disease, peripheral neuropathies, myopathies, and myelopathies. Treatment of HIV has really advanced over the years. Over the past 30 years, we've seen a huge advances in antiretroviral therapy, which suppresses HIV replication, leading to prolonged life and improved quality of life in HIV patients. And it also, from a public health standpoint, decreases transmission risk to uninfected partners. We know that of the 1.2 million people living with HIV in 2019, about 66% were receiving some type of HIV care. So now I want to briefly review some ethical principles before we get to our case. When we think about clinical ethics, we always want to consider respect for autonomy, beneficence, non-maleficence, and justice. So respect for autonomy is largely respecting a person's ability to self-rule or self-govern. It means respecting patients' values and wishes, even if they aren't in line with our own wishes or our own values and beliefs. Autonomy also includes truth-telling and issues of informed consent for procedures, and acknowledging and respecting other people's privacy and protecting confidential information. Beneficence, roughly translated, means to do good. So we want to make sure that we're acting in the best interests of patients, protecting and defending the rights of our patients, and helping patients with disabilities. Non-maleficence means that we don't want to inflict evil or harm on a person. We also want to protect our incompetent patients and avoid harm on them. And then justice. When we consider justice, we think, are our resources being distributed equitably? Do people have equal access to treatments and interventions? And how do we reduce inequality to promote greater well-being? So with that being said, we'll get to our case. So this is the case of patient G. This case is fictional, but based on real cases that we have seen in our clinical practice. So patient G is a 45-year-old woman with a history of advanced HIV/AIDS with a CD4 count of 26 and hypertension, who presents to the hospital with seizures following several weeks of severe headache and worsening confusion. She is found to have several large ring-enhancing lesions on CT, suspicious for primary CNS lymphoma. G is intubated for airway protection, initiated on steroids and anti-seizure drugs, and subsequently admitted to the ICU for further management. Unconscious since admission, G lacks decision-making capacity. For review of the medical records from primary care and infectious disease, it is well documented that the patient did not want her HIV status disclosed to family members, and she has repeatedly declined initiation of antiretroviral treatment. Her brother is listed as her healthcare agent per her advance directive. The medical team reaches out to the primary care provider, who confirms HIV status is something G felt strongly against sharing with friends and family members, including her brother. She is described by her PCP as a hardworking businesswoman and private person. Her reasons for not seeking treatment for her HIV are unknown. Primary CNS lymphoma in HIV patients is an AIDS-defining illness which carries poor prognosis without treatment. Treatment typically involves initiation of antiretroviral therapy and chemotherapy with high-dose methotrexate. Response to treatment is highly variable, and prognosis with treatment ranges from months to several years. Understanding that treatment of G's malignancy partially involves treating her underlying HIV, something she had previously strongly opposed, and knowing her wishes to avoid disclosure of her HIV status to family members, the medical team really struggles with how to proceed. Some team members feel it is necessary to disclose HIV status to the patient's brother in order to help him make an informed decision on treatment, while others believe the patient's autonomy should be respected and her wishes to keep her HIV status confidential preserved. So to help explore this case, we have our panel here, and I'd like to go ahead and let each of our panelists introduce themselves and their role here at Johns Hopkins. So we'll start with Dr. David Griffith.
Hi, everybody. My name is David Griffith. I'm an infectious disease physician here at Johns Hopkins. I am trained in internal medicine and pediatrics. So I work in our pediatric HIV clinic, in the Harriet Lane Clinic, and in our adult HIV clinic, the Bartlett Clinic. I also am the medical director of our county HIV program, where we provide HIV throughout the state of Maryland through county health departments. And pleasure being with you all today. I guess my role is as the HIV specialist.
And next, I'll invite Susan Longley. Go ahead and introduce yourself.
Hi, I'm Susan Longley. I am one of the senior counsel for Johns Hopkins Health System. By background, I was a trauma critical care nurse before going to law school, and I've been advising healthcare organizations for about 24 years now.
Great. Thank you, Susan. Next, I'd like to invite Theo Shaw to introduce.
Hi, I'm Theo Shaw. I'm a PhD candidate in health policy and management in the bioethics track at the Johns Hopkins Bloomberg School of Public Health. My background is in social work and bioethics. Nice to be with you all today.
Yeah. And last but not least, we'll have Molly Selmanoff introduce.
Hi, everyone. My name is Molly Selmanoff. I'm a clinical social worker on Nelson Floor, one of the medicine units at Johns Hopkins. And I think what's particularly interesting is that the floor that I'm on was historically the PULC service, which is the infectious disease service. So for the first year of my employment, I was working pretty solely with HIV patients, and now it is a OSLA residency term floor.
Thank you, Molly. And I will share a few references with you, and then I'm actually going to stop sharing the screen. So that we can all come back together. Great. So I'd like to start with Dr. Griffith and see if you could provide some comments about this case based on your experience as an HIV physician.
Sure. Thank you. So first, issues of disclosure amongst family is a very common thing that comes up in clinical practice. There's still a great deal of stigma towards patients who have HIV. And so it's something that each patient who's diagnosed needs to process and understand what the risks and benefits are of disclosing their status to their family members and other loved ones. What's a little unusual about this case is the lack of treatment. These days, we have so many good antiretroviral treatments for HIV. Most patients can take one pill once a day, which is very different from kind of in the 90s when patients were taking multiple pills throughout the day. So that the treatments are with minimal side effects and very easy. I say more commonly, a patient is struggling to take their medicines because of difficulty adhering to their medicine. They intend to take it, but are really struggling with mental health or competing priorities, which are preventing them from sticking to their medicines every day. I do see commonly patients who have difficulty accepting their diagnosis, and one way to kind of get it out of your mind is to just not take your medicine or go to your appointments. And so that's more of a passive choice not to take medicines. I say that's not uncommon for patients, but usually it's not a willful choice not to take medicines. Many patients with HIV feel fine, so they don't feel the need to take medicines, and it's much easier to ignore it than to kind of face it and come to the challenging acceptance process that many patients have to deal with. So maybe that's what was going on with this patient as well, and her choice not to take medicine. It can be a painful reminder every day, every time you take your medicine, of your underlying diagnosis if you haven't been able to process it or accept it. But issues of disclosure and stigma are quite common, and it's something that patients see every day, deal with every day.
Thank you so much. I'm now going to move on to Thea to get some of your thoughts on the case.
Sure. I wanted to touch on the way that the patient has made privacy around her diagnosis a priority in her life and clearly expressed her preferences here. I think it's noteworthy that her preferences are so consistently documented. It's often hard to figure out what people want, but in this case, this patient has really made it clear what she wants. And she's made that choice consistently with consistent communication with a trusted known provider. It's also worth noting that the choice of her brother as a healthcare agent may feel to the clinical team as though it's sort of at odds with the rest of her goals, but that choice may have been made in a different context than these sort of ongoing decisions about whether she's going to take medication and handle the fact that she has HIV. And in some communities, that choice may be typical or at least well within the range of ordinary decisions. As an HIV medical case manager, I worked at a clinic that many patients chose because it was the discrete choice. And for them, I think this was not so rare an occurrence. And what I learned from that experience is that keeping the secret is really challenging. We need to be aware of underlying tensions between patient privacy and sort of the logistical and interpersonal challenges of keeping the secret. The team needs to communicate to make sure that everyone's on the same page, manage their own discomfort with behavior that may feel wrong to them, and stay focused on the patient as the patient despite engaging with the family whose well-being of course concerns them. And the challenge here is that all of this well-intentioned action may be undermined by a single accidental disclosure, even by technology and the chart. So it really remains a challenge for the team as long as that secret is held. I also wanted to sort of push back, or at least note some challenge with the desire to know why. You know, the desire to know why she has this preference is perhaps rooted in a well-intentioned, ordinary desire to elicit her values and ensure that the care is in line with them. But it also might be rooted in a desire to undermine her very consistently expressed values. So there really is a tension here between finding something that you're going to support and finding something you're going to rebut.
Thank you, Thea. Next, we'll move on to Molly to give her general comments about it.
Sure. So from a social work perspective, the idea of beneficence and non-maleficence and autonomy are very important. What's most important, I would say, is going with her wishes, which she has stated time and time again, are not to inform her family or any decision makers of her HIV diagnosis. What we don't know, and I think what we need to dive into further, as this is clearly a complicated ethical issue with no easy answer, is whether or not she really had any idea that the CNS lymphoma could have come from the HIV. And it seems that in other parts of her life, she has determined that she wants her brother to be the decision maker. So whether or not this new diagnosis may change, if she were able to make a decision, whether it would change based on this new diagnosis, with the clear idea that she needs to have the antiretroviral in order to cure this new illness. And I saw this time and time again on the infectious disease service of patients that many patients, often the ones that actually had Dr. Griffith as a primary care doctor, who may have received or obtained HIV from their mother, and they were, what Dr. Griffith was saying is that they oftentimes were non-adherent with their medications because it was that daily reminder of that illness, that they had no part in becoming of themselves. So I think that's important to note, since we don't know where she got the HIV from.
Thanks, Molly. And last but not least, we'll move on to Susan.
Hi, so I guess I'm here to weigh in on whether or not there are laws and policies that actually address the disclosure of the information. So just to give you a bit of a background, everyone I'm sure is familiar with HIPAA. And in general, HIPAA addresses patient privacy and disclosure of protected health information. HIPAA would allow disclosure of PHI to the legally authorized surrogate decision maker, in this case, the healthcare agent. However, this case does present a more specific question regarding disclosure of a known HIV diagnosis to the patient's healthcare agent. When we look at Maryland law, I guess it's not surprising because otherwise we probably wouldn't be having this case discussion, but Maryland law does not have anything directly on point related to disclosure of a known diagnosis for medical decision-making purposes. There are a lot of statutes that address HIV. Most of them focus on initial testing and consent related to that initial testing, notification of those test results. There are a lot of statutes that are related to exposures. So it might be a correctional employee who is exposed, or a healthcare worker who's exposed, or a first responder. And there is mention of who you can share those test results with. And interestingly enough, all of those, virtually, all of them are the individual patient and the individual who's exposed. So there, although there's at least one statute that addresses substituted consent. Actually, there's more than one statute, but it is entertained that a patient might not have the capacity and the ability to consent on their own behalf. And so these statutes do recognize that there could be substituted consent for HIV testing, yet it doesn't include a language that would say that the test results can be disclosed to that substituted decision maker. There's also, it's also interesting to note that it is considered to be highly sensitive information, and there are some provisions related to reporting of test results where there is a duty by the physician or the ordering provider to report a diagnosis to the health department. And there's also a penalty associated with disclosing information that to someone who is not otherwise authorized to receive that information. So the good thing for our providers, of course, is that whenever there is testing and disclosure for some of these other indications, there is good faith protection. So good faith liability protection. For do you want me to get into like what Hopkins policy is and stuff at this point? Okay, I apologize. Yeah, Hopkins, so that's Maryland law. Hopkins policy, honestly, there is nothing that is specifically stated in policy. However, our position is that disclosure would be permissible to the legally authorized healthcare decision maker if it is medically germane to the decision or decisions that have to be made. And that's basically it.
So I want to pose a hypothetical, a different case to you guys. Let's say the patient came in with a massive hemorrhagic stroke, likely unrelated to her HIV illness, most likely due to her underlying hypertension, her high blood pressure. How would that kind of change things based on what Susan just said?
Well, it would seem to me that we wouldn't need to necessarily disclose the HIV. I guess either way, we don't necessarily need to disclose it, but that traumatic event that's occurred, if it's not related to the HIV, it seems like it would be less necessary to share the HIV status to the family member.
I would say, yeah, so the treatment of CNS lymphoma associated with HIV and a low CD4 count is antiretroviral therapy plus chemotherapy. So, right, the treatment would be, with HIV meds, would be part of the lymphoma treatment. I think, and obviously you wouldn't need that for the treatment of a stroke. However, long-term, this healthcare agent may still need to make decisions about their sister. So, and those decisions may revolve around medication in HIV. So maybe in the acute moment, it's less relevant, but long term, if that person is making all of their medical decisions, there may come a point where it would need to be addressed ultimately.
Thanks, David. As part of autonomy, truth telling is of course part of autonomy, and making sure that patients have informed consent. And so, David, thinking to your initial visits with patients, their initial diagnosis with HIV, what kind of things do you talk about with them in that initial visit to make sure that they have all the information you need about treatment versus non-treatment?
Yeah, so usually we start with what is HIV? How does it affect the immune system, and what are the risks of treatment? Really, we're using treatment to prevent the infections which can cause death, or the malignancies that can cause death. And I think patients really do understand that the treatment is to prevent those other outcomes. And I'll say patients I've had have all been very receptive to treatment with that understanding. And so there are patients who choose not to have treatment, or they maybe defer treatment initially. I've had patients who want to go more naturalistic treatment path, or more religious faith-based treatment approach. Ultimately, those patients have kind of come back and ended up on treatment. You can use if you don't go on treatment, the CD4 count will eventually decline. And so you can show patients, without medicine, your numbers are getting low. We know when it gets below 200, that's when you're at risk for infections. And sometimes for patients not taking medicine, it is an infection or hospitalization that maybe triggers them to rethink their own treatment approach. And so we should kind of summarize that in the first visit, so that patients really understand why they're taking the medicine when they may feel fine today.
Thanks so much. I also want to go back to harms a little bit, and I want to talk about the harms of disclosing HIV status. And, maybe Molly or Theo, you can talk a little bit about how stigma has maybe changed over time as it relates to HIV, or how it's still present.
I think that's a hard one to generalize about, right? I think for some communities, for some families, for some individuals, the stigma now has not really changed because they've had it touch their lives in ways that were hard to get over, or which left a particular mark. I think a real challenge in this case is that some of the harms that, as an ethicist, I want to point to are the harms to this woman who is unconscious. It's harms to her autonomy, it's harms to her privacy. But these are things that don't seem material to the clinical team in the moment, who's caring for her as a body, as a patient, and also for her family. And there, I think we need to also think about the harms that could be done to the family in having this disclosed to them. They're not going to only learn this information that might or might not be objectionable, we don't know, but also that this secret has been kept from them. They learn something new about their relationship with their family member that might be a very unpleasant surprise. I'm sure Molly has other things to add to that.
No, I think those are very good points. And again, as a clinician in the mental health field, as social workers, it is really important to keep those patients' wishes, however they are. Clearly for her, it's to not have her family know. But then as we were prepping for this session, something that came up that I just found so interesting was that if she does die of CNS lymphoma, it would likely say on the death certificate that it was, I think you said that it was secondary to HIV/AIDS. So I think no matter what, at some point, the family is going to find out that she did have HIV. And so then I think we get into the question of whether everything that you were saying, Theo, about this could be like contraindicated by what their beliefs are. They may not, they may have different feelings about the patient after they find this out. And then I think the question is that better to occur when she's living and when there are potential treatment options that they can actually use? Or, and I don't think there's one easy answer, or is it better to have them find that out on the death certificate after she is deceased?
Well, going little bit further than just on the death certificate. If you recall, we were talking about MyChart proxy access as well. And there actually is a process for the incapacitated patient, for the legally authorized decision maker to get MyChart proxy access. So what they do basically is, of note, it's only available to a true healthcare agent, not just to any surrogate decision maker. So it has to be a healthcare agent, which in this case, she had a healthcare agent. The process is you go online, you know, you have to answer specific questions. You have to upload your document, your advance directive or your healthcare power of attorney. And then it goes to the MyChart help desk queue for review and approval. So they look to see that it is actually a legally valid advance directive or healthcare power of attorney. And then, you know, they are given access. And of course, as y'all all know, we have an open record now. There is the ability to do information blocking in MyChart, but in this situation, when you're talking about a long-term diagnosis, that it would be very, very difficult, I think, to actually block all language or all information related to an HIV diagnosis. So kind of the rationale for why a healthcare agent is being allowed to get MyChart proxy access, even, you know, recognizing that there might be some information that they becomes known to them that they may not otherwise have known. The thought was that the patient was the one who chose the individual to make their medical decisions. And so it was either not have access, period, or take that step and allow the healthcare agent to have access.
Thanks, Susan. Another thing I kind of wanted to touch upon, especially from a palliative medicine perspective, is value-driven care. And I think, you know, this non-disclosure of HIV status really speaks to this patient's values of being a very, very private person. And I think that gives us a lot of information about her, you know, potentially end-of-life care for her. It also gives us information about, you know, her not wanting treatment for her HIV. And given that she has a diagnosis of AIDS and her prognosis without treatment is about 3 years, CNS lymphoma is likely going to shorten that. But we know that if she was, you know, given, you know, proper information at her physician's offices about the trajectory of HIV disease, that she knew that this would eventually lead to end of life for her. So I think that's one of the reasons why I asked Dr. Griffith about what they talk to patients about in an initial visit. Did she really know that, you know, her disease could ultimately lead to this CNS lymphoma, which would lead to her demise?
Yeah, I think that's something that does come up with patients who do get to this phase of their illness, and we will often frame it as, you know, you don't have to take medicines. You know, you can choose to manage this as you want, but without the medicines, you know, you're likely going to have more hospitalizations and a sooner death. And oftentimes that's a conversation that does help a patient reframe their goals, because that's when put in those terms, it's not what they want. But each patient is different, and I guess it is possible that a patient could choose this. I've had patients who have passively chosen not to take their medicines, almost as like a more passive suicide thought. Ultimately, those patients have kind of rethought things as they were able to get treatment and get better. So it is individualized, and you're right. I think each patient can choose what they want, but the important thing is making sure they understand. And I think often when patients do get sick and they truly understand what the future is without treatment, they do rethink. And this patient obviously doesn't have that opportunity to give us their current thoughts. So we have to just rely on what she had said previously.
I wanted to mention one additional harm that we haven't touched on, which is that the family that discovers this information after her death from the chart or from the death certificate, their relationship with medicine, their trust of medical institutions is likely to take a substantial hit, is to be harmed. And that may affect their willingness to engage in care in the future as well. This might have broader effects than just on this one family.
And speaking to something that's already kind of been touched upon is that, families can, as another harm, they can experience a tremendous amount of guilt, especially if this was a very supportive family who, really cared for this individual and couldn't understand why they wouldn't disclose this information to them and why they couldn't have been supportive of this person throughout the years. And so I think that can be a really, negative consequence of disclosing the HIV status.
So turning to going back actually to the fact that patients do change their mind in their treatment choices. Looking at the authorization for a surrogate healthcare decision maker, and in this case, a healthcare agent, the agent or the surrogate is supposed to base medical decisions on behalf of the patient on the wishes of the patient. And the brother could not very well base any decisions on the wishes of the patient unless he was aware of the diagnosis of the HIV status. So that makes it a little more complicated as well.
Susan, what if the advance directive specifically stated that the patient did not want any treatment for her HIV? That was not the case this was documented in the medical record, but not necessarily in the advance directive. What if the advance directive had explicitly stated?
Well, then the brother would have known she was HIV positive, right? So that would take care of one of our problems. And then I think it being that specific, I think that would kind of solve a lot of the issues. But you look at can you separate treatment of the HIV with treatment of the lymphoma? And what I'm hearing, what I heard was that you really can't. You've got to treat the underlying condition as well. Some advanced directives will have language in them that say that would authorize the healthcare agent to make a decision that is perhaps goes against an expressed wish that the patient has made if there is new information that would factor. And I think for purposes of this discussion, we had said this advanced directive didn't give them that authority, but there are those advanced directives that do, and that's why it's really important. We always say you're not a healthcare agent unless we have a copy of the advanced directive that we can look at to verify that it really meets all legal requirements. And so also so that we can specifically look at the language for just that type of thing.
Thanks so much. I want to make sure that all of our audience members have a chance to ask questions in the chat if they have any. So go ahead and type in questions in the chat. In the meantime, I wanted to ask another question. Dr. Griffith, given that you do both pediatrics and adults, I was wondering if you could talk about how things kind of differ in terms of disclosure for the pediatric and adolescent population?
Yeah, it is different. So we do have newly diagnosed teenagers in our clinic, and also patients who are coming to clinic for other kind of sexual health issues or prevention of HIV medications, and that information is protected for the patient. But the challenge arises with insurance. So many of our young people are on their parents' insurance. And so that's another level of potential disclosure when parents would get an explanation of benefits. So there are mechanisms to appeal to the insurance company to keep that apart. For the most part, with our young people, the parents do get involved. And then that is helpful. I personally don't have experience of a minor who had not disclosed their status to their parent or guardian. With my chart, oftentimes, you know, if we had a teenager who found out his diagnosis through my chart, because if it's not manually restricted, you know, the diagnosis can be made. They'll get the result before the clinician can even give them a call. So it does raise different issues when it is a minor and disclosure. But we try to, the other issue on the flip side, so for perinatal patients, they are often unaware of their diagnosis. We try to disclose to them around between the age of 10 and 12, really before they get into their teenage years, to inform them of their HIV status. Part of that is just before they become sexually active, before they start Googling their medicine on their own. Many young people start to ask questions anyway by that time. So we try to have a conversation, but some parents and guardians are resistant to that as well, and may delay that longer, but we do encourage it.
Thanks so much. We have a question in the chat. Could you speak to how outpatient clinicians would handle advanced care planning when the patient says they do not want the diagnosis disclosed to family? What if you were unconscious one day and your HIV was relevant to your care at a future time? What would you want us to do? So I think that's a really great question. And
yeah,
it kind of brings me back to whether or not this patient made that advance directive before or after her HIV diagnosis. So yeah, David, I'll turn that over to you.
Yeah, so since I've been invited to this lunch, I've thought more about this. It isn't something that I've thought of. I think I tend to take care of younger patients, but I think it's important for all ages, but especially patients who may be at risk of more severe disease. I had a patient recently who was diagnosed with a cancer. So I did pose this question because his daughter, who was going to be his healthcare agent, or he'd chosen as his healthcare agent, does not know of his status. And I said, so would it be okay if she found out if you weren't able to, if you were unconscious or unable to speak? And he said, yeah, that's fine if she finds out then. And we talked a little bit about how that would feel for her. And even kind of that conversation didn't really make him, at least to me in the moment, rethink disclosing to her sooner. So I do think a lot of patients, they really are firm in their belief of not wanting to disclose to family members. And maybe it is helpful to frame it like this moving forward with patients, so that we do understand when is it okay to do that if you don't want to be present and for that yourself.
Thanks so much. Obviously not something that most of us in outpatient medicine have encountered very frequently, but certainly a really important question in terms of advanced care planning. Something that I'll certainly consider in the future based on this case. We have another question here. What is the legal obligation to disclose to the parent of a minor? Susan, do you want to take a stab at this?
So I think it depends on the circumstances of the consent for testing. Minors have the same capacity as an adult to consent to HIV testing. So if they are authorizing or consenting on their own behalf, then then it would be the same scenario as the test result would be disclosed to them. And typically you would not, unless you have their permission, disclose that to the parent. And, you know, that obviously, as has been discussed previously, that can be complicated. You know, especially if they have MyChart proxy access already, or there's insurance involved and what have you. If it is the parent who is actually authorizing, consenting to the test, you know, again, the statute doesn't really anticipate testing of minors. You know, it looks to the patient consenting on their own behalf, or having a surrogate decision maker. A parent really isn't considered to be necessarily a surrogate, you know, unless and until the patient is of an age that, or the child is of an age that they could consent on their own behalf. So if the parent can, I would say, if it is a young child and the parent has consented, then we would be notifying, we would be providing that test result to the parent. But if it is a child who has consented on their own behalf, then we would not disclose without permission, likely.
Thanks so much, Susan. There we go. We have another question. If the healthcare agent was the patient's partner or significant other rather than a brother, and therefore potentially at risk of HIV transmission, does the need to disclose matter more than in just the treatment of the patient? So would you break confidentiality to warn the sexual partner, irrespective of surrogate decision making?
So part of the process when someone's diagnosed with HIV is the health department, so that every diagnosis of HIV is reportable to the health department. Patients' information are always disclosed to the health department. And then the health department has the Department of Partner Services, where they follow up with a diagnosed patient and get a history of who they may could potentially have been exposed through them, and then we'll follow up with those patients. And so that, I think, would be a potential mechanism here, is to disclose to the health department. Ultimately, if this person was their only sexual partner, they would make the connection very, very quickly. But I don't know, as the physician for the patient in the ICU, if I would go directly to the healthcare agent and disclose the status for their protection. I feel like there's other more formal mechanisms for that, but I'd be interested in other people's thoughts.
Yeah, so again, the disclosure or notification, it really focuses on notification of test results, right? So a known diagnosis is something totally different, but under Maryland law, if there is a positive test result, so in essence, a new diagnosis, there is a provision where a provider can notify sexual and needle sharing partners, independent of if the patient says, I'm not going to disclose, I'm not going to tell my partner. A provider could tell the sexual partner or needle sharing partners, or they, you know, as we talked about, they've got to report to the local health department anyway. And I think probably to maintain the physician-patient relationship, I think they probably would go down the route of going through the health department as opposed to independently calling a partner. But again, it really focuses on, Maryland law focuses on a positive test result. And in this situation, it's a known diagnosis, so very different.
I'm thinking about if the partner is a more recent partner and the test result was a while ago, so the health department notified or the physician notified previous partners that were potentially infected. but now this is a new partner and the patient did not tell them. I think what you're saying is that Maryland state law, since it's not a new test result, would not need to notify this new partner. Is that correct?
Well, it doesn't really get into that level of detail.
Okay.
So it doesn't entertain the idea that, hey, you could move on and have a new partner at some point. It's tied to the idea that there is a test and a test result that requires notification. So it doesn't really specifically address that.
Okay. So, because as I'm thinking back to being in graduate school, we did discuss not just HIV, but public health issues in general, and a lot of them having to do with disclosure of illnesses. And what I'm remembering from the social work framework, and this is not at all legally based, is that we would not necessarily tell new partners or tell anybody, and it would be completely up to the patient. Now, of course, we would encourage them to tell partners and to explain how this is a public health issue and it could harm other people and why it's so important to disclose, but really leaving that autonomy up to the patient. Different than this case because this one can't make a decision and she's not potentially infecting partners.
Yeah, and I apologize, I didn't go down the path of looking at the criminal statutes and all, but I believe that there actually is a personal responsibility under, I was looking at health general statutes and stuff, but I believe that there is a responsibility on the part of the individual not to expose someone, knowingly expose someone. And I guess you could perhaps not have to disclose if you were taking precautions, but still, there's a possibility that the individual, the onus is really on the individual, and there could be repercussions for failure to disclose.
David, in your patients who have known HIV, who are not virally suppressed, how do you kind of address the issue of new or frequent sexual partners?
Yeah, it's a challenge, and I think something that I have struggled with certainly in the past, and consulted some ethics, some of your colleagues over. We really try to stress that if we know the medicines work really well, and if you're on your medicines, your viral load will become undetectable, and if it's undetectable, your risk of transmission is essentially zero. And so we really use that as a strong incentive for patients to get on your medicines to decrease the risk to your partners. But I have had patients who are sexually active with elevated viral loads, and it's just a continued conversation about trying lots of different ways to talk to them about it, of the importance of communicating that with their partner. But it's something I struggle with.
I know we're trying to achieve as much of a sense of normalcy as possible for these patients. So it's also a struggle from that perspective as well.
And I'll also say too, just trying to maintain the patient relationship too. If a patient's not on their medicines, I'm doing everything I can to get them on their medicines, and certainly, wagging my finger at them is not going to help. And so it is quite delicate. I want to see them back in the clinic so they can get on their meds to decrease the risk of exposing other people. So it's quite delicate sometimes.
Thanks so much. Do any other panelists have any final comments or anything else that they'd like to talk about today?
I just sort of, like I said before, I think this is really helpful for me, and I think it does frame the way I will talk to patients in the future about advanced directives. So I appreciate you for putting it all together and sharing the case.
Yeah, and as somebody who does advanced directives with patients on a fairly regular basis, it's part of our social work assessment. It's very helpful to think of all these intricacies just based on the general Maryland Attorney General's advanced directive. There are so many other intricacies that could be added to help make a decision easier in the future, and also to help patients who may just say, yeah, I'll sign here, 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 but to really help them to understand what the decisions they're making, the implications it could have in the future.
Thanks so much. Well, we appreciate all of you coming together to be part of this panel today and giving multidisciplinary perspectives. I know from an internal medicine, palliative medicine perspective, I've certainly learned a lot in how we would proceed if we encountered more of these cases in the future. So thank you so much.